Okay, it's just a short video regarding venipuncture and cannulation within the department. As you see from our tray, it's quite different from what you would see on the wards. On the wards within NUH, they tend to use what's called cannulation packs. Down here we don't have them for financial reasons, also reasons of storage. So everything comes individually. So what we tend to do is we use the trays, lay them out in its own individual packet, but out of its packaging. This way it's neat, it's tidy, and no other risk of any cross-infection. So that is just a standard tray that what we use to go into a patient to cannulate and also remove, take bloods. Okay. Now, order of draw. So we'll come back to these bottles here. We have all the bottles we have within the department, and this is the order of draw that we go. So if we have a gas first, obviously we need 1 ml of gas to be taken to be adequately analysed. Anything more than that may be a failed aspiration. After that we need to go for cultures. So we've got aerobic first, which is your blue one, and anaerobic, which is your red or purple, depending on how you want to look at it. Next in line is your blue top for your coags. Very rarely used within the department, but may be requested, is a green top. Next in line would be a red top. These are more often used within the department for sort of like your serum saves for your patients that's been had needle stick injuries and stuff like that. Then you've got your SST, which is your gold top, EDTA purple, EDTA pink, group and saves, and obviously last but not least, which is obviously the grey top. We tend not to use the grey tops very rarely in the department now. In trauma it used to be used for lactates and sugars. We tend not to use that because with the gas we get everything we want off there. We get a lactate reading, we get a sugar reading, we get HB reading. So these have come sort of like obsolete within the department at present. We do a small stock is carried in case they're required, but very rarely used. Cannulate the patient and take some bloods. First of all, obviously obtaining consent from the patient that they are going to allow us to do this. Failure to do that can mean that you are classed as assaulting the patient. So for this, the patient has given us consent. We've got bloods, forms and identification on, so we know who the patient is and what we're actually taking. We've asked date of birth and who they are, and that all marries up so we can proceed as normal. We're applying a tourniquet, and obviously while we're doing this we're going to talk to the patient, tell them what we're doing and keep them comfortable and reassured all the way through. We've put the tourniquet on, we're looking around, we're having a feel. Obviously we want to start distal, and for this purposes we're going to go for the cephalic here. It feels nice, it's got a good elasticity, and it'll do for what we want. So I've got everything in place that I require. We're going to clean the area thoroughly before insertion of any needles. I've prepped my cannula, wings are down, sheath off, and I'm keeping my fingers behind the needle. I'm applying some pressure either side so as to hold the vein perfectly in line. Slight angle going in. Wait for my flashback. I've got a flashback, just advancing it that little bit extra, popping the needle out, and then I'm just going to slowly insert the needle. I'm feeling along where the catheter is inserted into the vein, and I'm pressing just beyond that, and I'm withdrawing the needle. These are safety needles and they lock off automatically, as you can see. And then we're going to take my gas and insert it. Always continuing to hold the cannulate all the time, just in case the patient moves. What I'm doing is I'm withdrawing the bloods now, and we need approximately 1 mil. That's completed. That container on. Order of draw again. With these I've got 3 bottles, and the first one is going to be the blue one. So I'm applying that, waiting for it to fill. It stopped. Holding this firmly and pushing against here and removing it. What I'm actually doing is I'm just checking on the actual bottle. With the blue ones, there's anticoagulant that's in there, and it's defined with the amount of blood that's filled. Towards the top of the neck there's a little line, if you can see. It needs to be to that line and not below it. If it's below, the labs will return the sample as insufficient. We're going for the SST, which is the gold top. Full. With the bloods, we're just inverting a few times. We're not shaking like this. That starts to damage cells and also starts to give us false readings, normally on the potassium and other chemical balances. Then we're going to go for a ZDTA, which is our purple top. Same again, inversion a few times just to mix the anticoagulant. I've removed the tourniquet. I'm applying pressure again on the vein, removing that container. Applying my bung that's already connected to my saline, and I'm making sure that's nice and firm. While I'm doing that, I'm holding it in place, and I'm applying my little tabs that's going over my wings to secure it in place. Then what I'm doing is I'm just gently flushing the cannula, just making sure there's no resistance, looking for any hematomas to say that it's blown, and that's flowing lovely. Then I'm holding the actual bung, turning anti-clockwise and removing that. Applying an IV fix. As you can see, the actual date that the cannula has been inserted is put on the side, and all cannulas that we insert stay in the patient for 72 hours and no more. This may be increased if the patient is difficult to bleed, the consultant or the medical staff say that it can stay in, but normally 72 hours. If a patient comes in cannulated by EMAS or any pre-hospital care provider, that will be removed after 24 hours. We can't guarantee that aseptic techniques was used to insert these devices. In the pre-hospital environment, they could have been upside down cars, in dirty houses and everything else. So where EMAS is concerned, we remove that after 24 hours, we would remove after 72. Once that's done and dusted, bloods are taken away, labelled and sent, and then what we'd do is I'd go on to Medway, and then I would fill in my VIPS form saying that what size of cannula was used, where it's been placed, and that I put it in. So it's an actual documented record of who's placed it in.